Morning, everyone, for coming here. Thanks for coming here this morning. And I know a lot of us have joined over Zoom, and will continue to trickle in as the day goes on. Today, we have the great pleasure of welcoming Dr. Quinn Capers here. Dr. Capers is the Rody Cox Professor of Medicine and Vice Chair for Diversity and Inclusion in the Department of Internal Medicine at UT Southwestern Medical Center, my alma mater. He also serves as the Associate Dean for Faculty Diversity and is an interventional cardiologist with a long career at the Ohio State University before moving to UT Southwestern. He finished his medical degree at the OSU, his residency, fellowship, interventional cardiology fellowship, and vascular research at Emory before going back to OSU as a faculty member. Dr. Capers' clinical and academic interests, of course, focus on interventional cardiology, but he's been really engaged in enhancing medical education, especially early career training, and has focused most of his efforts on racial healthcare disparities and how to enhance diversity in our training environments. As a nationally recognized leader of diversity and inclusion in academic medicine, Dr. Capers has given lectures and has an amazing workshop on implicit bias training in medical care. And if you haven't taken that before and get an opportunity, I would strongly recommend doing that. And I'm really happy that he decided to visit us, and I'm really looking forward to his talk on evidence-based medicine means following the evidence that diversity saves lives and acting accordingly. Dr. Capers.
Thank you so much, Dr. Kira. Thank you for the invitation, and good morning, everybody. My first time in New Haven. I'm happy to be here. And I want to talk about diversity, especially as I'm sure is no surprise to anybody listening or anybody in the room, the idea, the concept of working actively to enhance diversity in higher education, in medicine, is really coming under attack. And we're moving into an interesting phase in this country because it's not just a few individuals that criticize efforts to enhance diversity, but now our state legislators, our lawmakers are making moves to do so. And so it seemed like a good time to talk about the importance and where does the evidence come from. This is something that we should do. So okay. All right. So let me start. Thank you very much. Yep. Making a statement that, what we do, what we've dedicated our lives to, medicine, will never really reach its full potential to alleviate suffering and improve lives until it leverages talent from all backgrounds. Still not going for me. Yep. Should I do it from here? There we go. All right, good. So a word about social media. Now, I know when I talk about Twitter, talk about social media, I get it. It can be used for evil purposes, but it can also be used for good purposes. And so I want to talk a little bit about Twitter. One of the things I like about Twitter, I'm active on Twitter, is you can create a poll and you can see kind of how your followers or others feel about a certain topic. And so I asked this question when I did a poll, got about 1,000 people voting. This was the question. So please answer honestly, thoughtfully, and retweet. If a colleague were to ask you, why do we need more diversity in medicine? I would have a strong evidence-supported answer. Oh, you're not seeing that? Got it. Okay. Thank you very much. Yep. So this is the question on the poll. If somebody challenged you, why? Why do we want diversity in medicine? I would have a strong evidence-supported answer. And then I gave kind of a Likert scale. And as you can see, about 75% said strongly agree or agree, with about a quarter saying disagree or strongly disagree. And so then I looked at some of the actual responses. And this is, I'm showing his face. It's okay. He's a buddy of mine. Carl is a pulmonologist. We were classmates at Ohio State. Carl said, I put disagree because while I agree with the premise, I don't have the data in my field on the top of my head. And there were a lot of answers like that. Here's one that says, it's a great question. I definitely support it, meaning diversity, but it's based on experience with the population I serve, but I lack knowledge of academic evidence to make my argument. And somebody else said, well, it's an interesting question, but I couldn't readily quote the data or the literature in the debate. So that got me thinking about this audience. So I know that in your heart and your soul, you know that diversity is a good thing, but if you were challenged, somebody challenged you and said, why? Why should we try to diversify our medical school, our residency, our fellowship program, our faculty? Would you be able to quote them studies? Like if somebody asked you, why do we use Entresto in heart failure? I bet you'd be able to quote the studies. If they asked you, why should we do early invasive strategy in acute coronary syndrome? You could quote studies. But if they asked you, why should we try to enhance diversity? Would you be able to quote studies? Or would you be a little locked up? And that is the purpose of my comments to you today. So I'll put it in the form of a multiple choice question because we're all, you got where you are because you're a good test taker. And so, okay. One more like that. No. Thank you. It's good to have good help. Appreciate you, Rohan. Okay. All right, good. So, those are my words. Hello, my name is Quinn Capers. Look at that, it worked. Thank you. Thank you. So put this in the form of a multiple choice question. So why do we seek diversity in medicine? And let me tell you at the beginning, this is a single best answer type multiple choice question. And so do we seek diversity because A, physicians who train in diverse environments rate themselves as more comfortable treating minority patients, or is it B, because underrepresented minority physicians are more likely to serve the underserved? Maybe it's C, minority patients are more likely to follow the recommendations of minority physicians. Maybe the answer is D, because if you have diversity on research teams, it'll enhance the impact of the research. Or maybe it's E, that diversity in medicine should and will help reduce racial healthcare disparities. Remember, this is a single best answer type multiple choice question. And as you know, because you've done well on tests in your life, one of the best ways to approach a multiple choice question is first you cross out the incorrect answers, the ones that you know are incorrect. And then you're left with maybe one or two and you kind of got to struggle to get the answer there. So I want you to do well on this test. So I'm going to help give you some background information first. So first I want to show you this study published in 2008 by Saha, where what they did was they asked graduating medical students across the country about their own comfort level treating patients who belong to a different demographic group, religion, race, ethnicity than them. And then they went back and looked at the compositional diversity in the student body where they went to medical school, and they saw there was a relationship. The more diverse was the student body, the more comfortable they were treating patients of different backgrounds. And so in the comments, in the summary, is that in this cohort of more than 20,000 graduating students, white students, because that was really the focus of the study, white students who attended more racially diverse schools rated themselves as better prepared than students at less diverse schools to treat minority patients. So there's something about the training milieu. When we interact with each other, people from different backgrounds, we are then more comfortable interacting with people from different backgrounds. So some of you might like A as the answer. Which brings me to this analysis in brief from the AAMC. And what I'll remind you is something, some of you may be young enough to remember this when you were in medical school. Your first week in medical school, if you went to a AAMC medical school, during orientation week, you took a survey. And then your last week, graduation week, you took the same survey that wanted to see how you change your answers. One of the questions asked is, and in this analysis, they looked at results for 80,000 students. Do you plan to locate your practice in an underserved area? So they were asked that, these students, at the beginning of medical school and at the end of medical school. And the Black and Hispanic students were more likely to answer yes. The white and Asian students were more likely to answer no. But the purpose of this analysis was to look at those students who were undecided, because you had three choices. You could say yes, no, or undecided. So they looked at those students who were undecided at the beginning of medical school, and then they looked to see if they had changed their mind by the end of medical school. The Black and Hispanic students that were initially undecided were more likely to answer yes by graduation. And the white and Asian students who were initially undecided were more likely to answer no by graduation. So think about that. And this is, I think, a lesson for those who work with curricula in medical school. What's happening in medical school? What's happening in those 4 years that's making Black students who were initially undecided, Hispanic students who were initially undecided, by the time they graduate, say, yes, I would like to serve underserved populations. And what's happening in medical school that's making our white and Asian students who were initially undecided, by the time they graduate, say, no, I don't think I want to serve underserved populations. So I want our curricular folks to pay attention to that. So this is 80,000 students. And what I want to do now is show you this slide on which I failed to do what I set out to do. What I set out to do was put on one slide every study that has ever shown that doctors from underrepresented minority backgrounds, which we define as Hispanic, African American, Native American, Native Alaskan, Native Pacific Islander, every study that has shown that doctors from those backgrounds are more likely than doctors of other backgrounds to serve underserved populations. But I failed because the slide wasn't big enough. So you'll have to settle for 10 studies from 4 different decades that remarkably all show the same thing. If there's anything in this field of diversity, equity, inclusion that is a done deal, that we don't have to study anymore because we know the answer, it is this. Doctors from underserved backgrounds are more likely to have it in their heart and soul that they want to go back and serve underserved populations. So I showed you how they enter medical school. This is showing that it's not just talk. After they graduate and complete their residency and pass their boards, this is what they're doing out in practice. So some of you might like B as the answer. So let's move on. You're looking here at a photograph from a paper, again by Saha, published in 2020, that used not standardized patients. You know what those are. Those are actors playing the role of patients, but standardized doctors. Actors playing the role of doctors, and they play the role of us, cardiologists. So these actors that you see here, you see they're men and women, Blacks and whites, they played the role of a cardiologist, and they all read an identical script. And the script said, I've reviewed your tests. You need open heart surgery. I recommend that you have the open heart surgery. The viewers of the test were actually heart patients. So they actually rounded up patients who were being treated for heart disease, and they let them look at the videos. So each patient only saw one video. And then they simply asked them a question and said, well, based on what you've heard, will you have the heart surgery? The results showed that the Black patients were more likely to respond, yes, I'll have the surgery, if it was recommended by a Black doctor. And I couple with that on the same slide, this incredible study by Alson and colleagues out of Oakland, California, not too long ago, that showed that when Black male patients specifically are treated by Black male doctors, as opposed to white doctors, as opposed to Asian doctors, they are more likely to comply with the recommendations to get a vaccination and to get their blood and cholesterol checked. So that means if you're counting, that means if we had more Black doctors, more Black patients would get their vaccinations, would get their blood sugar checked, would get their cholesterol checked, and if they need open heart surgery, would have their open heart surgery. So you might like C as the answer, but we're not finished yet. I love this study by Alshabli and colleagues. They had a question, and the question was, does the impact of racial and ethnic diversity on the research team have anything to do with the impact, the number of citations of the research study that is published? So what they did is they analyzed over 9 million papers, 9 million, that's a lot of reading. And they studied the relationship between what they called impact, which was number of times that the research study was cited, and several different types of diversity. And the strongest relationship, there was a strong relationship with racial and ethnic diversity on the research team. So that means if you're, this suggests that if you're primarily a researcher in this audience, you want your research to have impact, then you want racial and ethnic diversity on your research team. This is not the only study that has shown that that can actually have a positive impact on the innovative nature of the research and how widely read your research is. Now I'm going to talk about something near and dear to all of us, and something that probably keeps all of us up at night, or at least it has a time or two, and that is racial healthcare disparities in our field, in cardiology. And we live at a time where we have some wonderful tools to prolong the lives of our patients and improve their quality of life. We have AICDs, we have primary PCI for STEMIs, and a treatment for critical limb ischemia. But let's go on rounds, if you will, and put on our white coat and go and see some patients. And here's what I want to ask you. If these two patients, and this is nationwide data that I'm showing you, and let's say you have two patients here with severe congestive heart failure, refractory to medicine, and an ejection fraction less than 35%. They're qualified. They meet the ACC AHA guidelines for an AICD. Who gets it? I'm pretty sure in your mind you're saying, oh, of course, both. But that's not what's happening across this nation. Across this nation, in this picture, the white male would be more likely than the Black woman to get the AICD, even when they have an identical diagnosis. Let's talk about acute coronary syndrome next. We're making rounds. Now we're going down to the ER. We got two patients having an acute coronary syndrome, either unstable angina or non-STEMI or a STEMI. Who gets timely cardiac intervention? What we know in our field is that the faster we get you to the cath lab, do the angiogram, see the blocked artery, and open it, the more heart muscle we salvage, the more likely we are to save your life. I'm sure when I ask this question on the slide, you're saying to yourself, well, of course, both of them. But that's not what's happening in this nation year in, year out. Let me give you some data to back that up. Ashraf and colleagues published this recently this year in Current Problems of Cardiology. They looked at over 80,000 patients in the United States presenting with a non-ST segment elevation myocardial infarction. And they looked at 5 different time points from 2005 to 2019, the likelihood of having a cardiac cath. So they presented to the hospital with an acute coronary syndrome. They ruled in for a non-STEMI, the likelihood of having a cardiac catheterization. As you can see, catheterization rates went up for all, but this one is comparing whites to Blacks. So whites were more likely across this nation to have a cardiac cath than Blacks when they presented with a heart attack. This one is looking at whites versus Asians. So whites were more likely than Asians to have cardiac cath when presenting with a heart attack. And at all time points, this is looking at Hispanics. So while it seems like a terrible thing to say, the way to be sure that you're going to get a heart cath if you present with a heart attack is to be white. If you are white, your chances of having a heart cath procedure showing where the blocked artery is higher than Blacks and Asians and Hispanics. So we have a problem, and this is as late as 2019. What about critical lower extremity ischemia? 2 patients present with, let's say, a pulseless blue foot, critical limb ischemia. Who gets revascularization and who gets amputation? I'm sure in your mind you're saying they both get the very best care available. That is not what's happening in this country. In this country, the white man in this photo is more likely to have a complex revascularization. The Black man is more likely to have a limb amputation. Let me back that up with some data. This is a recent study, 2023, which looked at thousands of patients. Again, this is all national data, not one region or the other, national databases. And what they looked at was patients presenting with critical limb ischemia, who gets revascularization and who gets an amputation. So these are the odds ratio for receiving an amputation compared to whites. Blacks were 30% more likely. Hispanics were 59% more likely to have a limb amputation. And I know what you're thinking. You're thinking what you should be thinking because you are intelligent physicians and intelligent scientists. You're saying, well, hold on now. What about the extent of disease at presentation? Because we know that patients from underrepresented or disadvantaged backgrounds tend to present much later in their course. And so if you present to the emergency room with an ischemic foot and all the blood vessels from your groin to your toe are occluded, well, there's nothing that a surgeon can do. There's nothing to bypass into. There's nothing to stent open. There really may be no other choice than to send you for an amputation. Well, what these researchers did is something that hadn't been done in enough of these studies. They said, let's go back. This is the unadjusted data. This is just taking the outcomes of amputation. Well, let's go back, they said, and let's adjust it for the extent of disease and the severity of disease at presentation, because surely the disparities will then go away. So I want you to pay attention to these odds ratios, 30% and 59%. When they adjusted for extent and severity of disease, look what happened. Practically nothing. It was almost the same. So despite the extent and severity of disease, you still had these shocking disparities. Then they said, well, we got to make this disparity go away. So So let's control for payer mix. Let's control for hospital type. Let's control for geography, where they are. Let's control for everything we can. And then finally, they did see that some of the disparity went away. After controlling for everything that you and I can think of, then the Blacks were only 12% more likely, and the Hispanics were only 34% more likely to have an amputation. They couldn't make it go away. Their final statement was, despite adjusting for severity, insurance status, comorbidities, the disparities continued to persist. So despite the fact that we have such wonderful tools to treat our patients, Blacks and Hispanics are less likely than whites to receive AICDs when indicated. Minorities, and here I mean Hispanics, Blacks, and Asians, suffering from heart attacks are less likely than whites to have timely coronary procedures. And compared to whites with critical lower extremity, Blacks and Hispanics are more likely to have limb amputation. So we have a problem. We have severe racial healthcare disparities when it comes to cardiovascular care and cardiovascular procedures. What I want to say to you is what you likely already know is that this is not new. In fact, some of the first studies to show racial differences in these disparities started to come up in the 90s. They continue to come up. So now we're entering our fourth decade, the 90s to 2000s, 2010s to 2020s, fourth decade of peer review literature documenting these racial disparities in cardiovascular care. We did a review study, and in our review article, we talked about the fact that in a 20-year period, there were no fewer than 300 papers documenting these racial disparities. So 300 times. This is just in cardiology. And what we talked about is that the sobering thing we found is that things were just as bad at the end of that 20-year period and documenting the problem 300 times as they were at the beginning of that period. So documenting the problem again and again and again and again has not led to much significant change. But there's something else that has been stubbornly present through that time, and that is a severe lack of diversity in our field. While the US Census says that 51% of American adults identify as women, only 13% of cardiologists are women. 17% of Americans identify as Hispanics, yet only 5% of cardiologists are Hispanics. 13% identify as Black. Not even 3% of cardiologists are Black. There are some, and you can count me in this number, who think that those other numbers won't improve until this number improves. And that's why this is such an important study here by Snyder and colleagues. Sorry, that got cut off. Snyder, JAMA Network Open 2023. This is going to be a widely quoted study because what they did is they looked at all the counties in the United States. Interestingly, they found that of all the counties in the United States, half of them, 50%, don't have one, not a single Black doctor, Black primary care physician. But they found 1,618 counties that had at least one Black primary care physician. They found that the greater the number of Black primary care physicians, the higher the life expectancy for Blacks in that county. They found that the greater the number of Black physicians, the lower all-cause Black mortality and the lower the like outcome disparity between Blacks and whites in that county. In fact, they calculated that for every 10% increase in the representation of Black primary care physicians, there was a higher life expectancy of 31 days for Blacks living in that county. So while we've had many studies that have shown the positive effects of racial concordance between patients and doctors, most of them have to do with improved communication, improved compliance with recommendations. This is one of the first and important to show that patients live longer. Black patients live longer if there are more Black doctors around. Very powerful. And so it's now time to finish up your quiz. So why do we seek diversity in medicine? Is it because physicians who train in diverse environments rate themselves as more comfortable treating minority patients? Or is it because underrepresented minority physicians are more likely to serve the underserved? Is it because minority patients are more likely to follow the recommendations of minority physicians? Or because diversity on research team enhances the impact of research? Or maybe it's because Diversity will help us reduce racial healthcare disparities. Again, this is a single best answer type multiple choice question. So hopefully you've crossed out enough and you've left with the answer. So Yale University, what's the answer? Somebody said B. Somebody said F. Yes, yes. So as my friends told me, said, Quinn, they're really smart at Yale. They're going to get this right. So you're absolutely right. All of the above. So all of the above are true. And I could have taken up more time in our talk, showing you more and more data, but I had to cut it off somewhere. And so now I hope that you have a strong evidence-supported answer if you are challenged. Why? Why do we seek diversity? We have good reasons, and just like you can stand toe-to-toe and look somebody in the eye and tell them why you use Entresto and heart failure, hopefully now you can stand toe-to-toe and tell somebody why we should have more diversity in medicine. So the next question is, why aren't we there yet? So if the evidence-based peer-reviewed literature supports it, that not only will it enhance compliance and all these other things, but it will prolong life, why aren't we there yet? It should be a pretty simple composition. It's because not everybody believes it. Not everybody believes that we should enhance diversity in medicine. I know that's a strong statement, but let me back that up also with some evidence. So I'm going to show you the results of a survey done by the Society of Thoracic Surgeons. So the Society of Thoracic Surgeons, they realize that cardiovascular surgery, like cardiology, is not very diverse, and they want to do something about it. So in the SCS, they have a diversity committee. That diversity committee, one of the first things they did was survey their membership. So they asked them about various aspects of diversity or the lack of diversity in cardiothoracic surgery. But as is often the case with these kind of surveys, the real gold, the real good stuff that you get was the answer to the very last question, that open-ended question where you say, tell us whatever you want to about this topic. And I'm going to share some of those answers with you. So somebody said this, that white males are currently being discriminated against in admission to college, med school, and residency programs. CT surgery should be a meritocracy. Someone else said, I do not believe barriers exist. This myth of the necessity of diversity and inclusiveness is political correctness on steroids. We need to worry about turning out well-trained residents. Somebody else said the STS doesn't need to address diversity. And quite frankly, this shouldn't even be on the radar of things to be done. And finally, somebody said barriers. Barriers? What barriers? There are no barriers, and none of the above are important. Now, those are our colleagues, the cardiothoracic surgeons. So we want to be fair. We don't want to just pick on them. And so I sit on and I lead the ACC's Diversity and Inclusion Committee. So one of the things we wanted to do, knowing that our specialty is not very diverse, so we wanted to survey program directors, the gatekeepers, right? Because you don't get to be a cardiologist or a cardiology fellow unless you get by that cardiology fellowship program director and their selection committee. So we did a survey where we're asking them about how they feel about certain aspects of diversity. 57% of cardiology fellowship programs in the United States were represented among those who responded to this survey. This is one of the questions we asked. We said diversity is a driver of excellence in healthcare delivery. In other words, the more diversity amongst your providers, the better the care delivered. Do you believe this? Fortunately, almost 75% said yes. 5% said no, I don't believe that. And 25% said maybe. So that's 30%. 30% of the program directors who responded to our survey aren't sure if diversity enhances quality. Another thing we did is we gave on the survey 10 characteristics of cardiology fellowship applicants. So we're giving you these 10. We want you to rank them. Rank them as to which are on your mind, are most important when you are making your rank list. And here are the results. So the number one vote getter was clinical skills. I do not have a problem with that, and I'm sure you don't either. You can see number two, though, was ability to fit in. Ability to fit in. And I wonder what that means. I wonder if that means the same thing to you as it does to me. But you can let your eyes go all the way down to the bottom, and that's where you will find at the bottom diversity, or the ability to enhance the cultural competency of the program. It was literally the last thing on the minds of cardiology fellowship program directors when they're making their rank list. And this, again, was published in 2020. So not everybody believes what you and I believe, that diversity is something that we should strive for, but the jury is in. You've just seen that diversity leads to increased cultural competency of all doctors. Listen, if I'm training with doctors from Korea, if I'm rounding with them and I'm listening to lectures with them, I learn a little something maybe about Korean culture. And at the very least, what I learn is that individuals from Korea have the same hopes and dreams that I do, have the same fears that I do, and have wonderful attributes. And so when I treat a patient who is Korean, that patient benefits from that. In the same light, those doctors rounding with me, they're rounding with this Black kid from Dayton, Ohio. They learn a little something about Black people, about our hopes and fears, and hopefully they see some attributes that are positive. And then when they treat a Black person, that Black patient benefits from that. So we all benefit when we are in a diverse milieu, and most importantly, our patients benefit. More doctors dedicated to serving underserved communities if we're more diverse. Minority patients are more adherent, we'll have enhanced research, and finally, more lives will be saved. So we've got to do this. So now let's turn the corner and talk about some ways that we can all engage in and we all can do more and more and more of. Recruit. And when I say deep in the supply chain, I'm talking elementary school. We can go all the way back in the pipeline. We need to recruit from the immediate supply chain. And these are college students, medical students, and residents. We have bias. In medicine, we have bias in our selection processes. We need to courageously confront that bias. What if we took diversity competency, or the ability to enhance the cultural competency of the program, or the ability to advocate for health equity in that field, and we elevated it to a top 3 consideration when we're deciding who gets into medical school, residency, fellowship, and who we recruit to our faculty? What would that look like? And then finally, our trainees are watching us. It's time now to be an activist, to step out, to make some noise. You could be an activist through your scholarship. Many of you are. You could be an activist by marching. You could be an activist by writing your legislators. But it's time to be an activist against those things that have seemed immovable, right? Social determinants of health. Every time I hear a lecture on social determinants of health and its impact on healthcare, I kind of start getting this feeling of helplessness. Like, man, what can we do about that? If they don't have clean water in this community, what can I, a cardiologist, do about that? But there are things that we can do about that. And let's just go through these. Recruit deep in the supply chain. And when I say deep, I mean deep. Look at these kindergartners. These kindergartners are having their white coat ceremony. And this is a picture from the K through 12 Health Sciences Academy in Columbus, Ohio, that is a collaboration between the Ohio State University Medical Center and Columbus City Schools. From kindergarten through the 12th grade, these kids are going to have the health sciences in their curriculum. And this is maybe the best part, once a quarter, they're going to actually have a panel discussion and meet with medical students, dental students, pharmacy students, nursing students. The hope is that by the time they're graduating high school, the idea of being a doctor is going to seem like no big deal. I've been around doctors and talking to doctors my entire life. Very proud that at UT Southwestern, we now are collaborating with Dallas Independent School District, and UT Southwestern now has an elementary school, a K through 5 school that's on campus that we are going to collaborate with and co-run along with the Dallas Independent School District. This is reaching back into the deep supply chain. And you don't have to do such a grandiose gesture. You can go to Career Day. You can bring the kids here to do some things with your clinical skills center. But these kind of impacts, we think, are going to help that supply chain of physicians. We need to recruit in the immediate supply chain. You know, we've surveyed internal medicine residents, the ACC Diversity and Inclusion Committee, and we want to know why is it that almost 50% of internal medicine residents are women, but when you look at cardiology fellows, it falls off a cliff down to about 13%. What's happening? We've surveyed women internal medicine residents, and we know some of the answer to that. And some of that is a lack of mentoring, a role model. Some of it is that our specialty still comes off very much as a boys' club, comes off as not very friendly to women. So there are some things we can do to recruit in the immediate supply chain. One of the things for which I'm most proud with the ACC's Diversity and Inclusion Committee is our internal medicine mentoring program, where we are mentoring internal medicine residents who aspire to be cardiologists. We have 4 cohorts. We have a cohort of African-American residents, of women residents, of Hispanic residents, and we've recently launched a new cohort of residents who identify as members of the LGBTQ plus community. Total about 500 internal medicine residents. Our pledge is to mentor them until they are the most competitive cardiology fellowship applicants they can be. There are no guarantees, but for a lot of these people who might be first generation physicians, there are little things that they don't know. If I'm doing my residency at a community program, how can I get involved in research? How important is research? What kind of research should I do? How many programs should I apply to? Do you know the answer to that? When I was the Dean of Admissions at Ohio State University, the medical school, we knew that answer when a pre-med student would ask us, how many schools should I apply to? We had the data. The average applicant who is successful at getting into medical school applied to at least 16 schools. So we could say to a pre-med student, you're making your list, it shouldn't be less than 16. Maybe it needs to be more than 16, but it shouldn't be less than 16. If your internal medicine resident mentee asks you, how many programs should I apply to? Do you know the answer to that question? So in this group, we hooked them up with an ACC mentor. They meet with their mentor quarterly. And once a year, guess what we do? We fly them all to the ACC meeting. So this is now one of my favorite selfies. Standing behind me, you see 400 internal medicine residents who identify as Black, Hispanic, women, who want to be cardiologists that we've flown to ACC, and they're going to meet with their mentors and just enjoy the specialty of cardiology. By the way, here's the time for me to put in a plug. We need mentors. So please reach out to ACC, reach out to me. We need mentors. We want every one of these individuals to have a mentor that they meet with virtually once a quarter to just talk about, you don't have to know the nitty-gritty details about applying to cardiology fellowship, because we have several panel discussions for them with program directors. But for them to simply interact with a cardiologist, we need you. You can make a great difference. Number 3, be courageous about calling out bias, identify it and mitigate it in medicine for healthcare disparities and also in our selection processes. So when I was at Ohio State, we actually had our entire admissions committee, which is very large, 140 people, take these online implicit association tests. And what we found was that more than half of the admissions committee had unconscious negative biases about Black people, about women, and about members of the LGBTQ plus community. They're human, wonderful individuals. So that was shocking. But then the next thing we did is we went right into a bias mitigation workshop, because it actually is very easy to overcome your unconscious biases. There's a few simple steps to take. And what did we find? We found that the next class that matriculated was the most diverse in our medical school's history at that time. So we immediately made bias mitigation training an annual requirement for serving on the admissions committee. We at UT Southwestern have started doing something we call bias and equity rounds. We're at our grand rounds, at internal medicine grand rounds, 2 to 3 times a year. We do kind of an M&M, kind of a morbidity and mortality, not about patient outcomes, but about instances of bias and racism in the medical establishment that happened in the last quarter. We de-identify the cases. So it's case-based, and here's an example of what we do. We might say, we have residents and fellows and nurses present us cases. We de-identify them because we don't want to embarrass anybody. And an example of the way we do it is we might present a case where a patient with new onset congestive heart failure, who's African-American, this is a real case, the house staff team had done the appropriate job. They'd worked him up and they ordered an HIV test and a drug screen. And then the attending, who in this case actually happened to be me, said, why did we get the urine drug screen on this patient? And there was a lot of murmuring and babbling, and they couldn't really answer why. And then I pointed out to them that just last week, we admitted 2 white patients with new onset congestive heart failure. Nobody ordered a drug screen on them. Was there something seen in this patient's presentation? Something said during the history? And there really wasn't. And so that allowed time to have an impromptu kind of talk about bias in healthcare. So at our bias and equity rounds, we would present that as a case, and then audience response. We then ask the audience, is this an issue of bias, yes or no? Next question. If it is bias, is it implicit or explicit? Next question. Did this example of bias impact patient care? And then we have an expert get up and talk about how we can overcome this and make sure it doesn't happen next quarter. We call those bias and equity rounds. We do them 2 or 3 times a year in our internal medicine department. Our surgery department has started to do the same thing, and we hope, obviously, that this catches on. Elevate diversity competency to a top consideration. What would it look like if we did that when we're making our selection processes? In this perspective piece, we published in Cath and Cardiovascular Intervention that we call Black Lives Matter in the Cath Lab 2. We talked about a system that we had when I was a program director of the interventional cardiology program at Ohio State for selection. It was a total point score system. So our applicants got total points, and the points were equal for each of these bullet points for clinical skills, for collegiality, academic curiosity, leadership potential, and what we call their diversity competency, which is their likelihood to promote health equity in the field based on what they've done in the past and their answers to some questions. And they could tell you, let me tell you, this is who I want doing my heart cath. Somebody who's got great clinical skills, somebody who's collegial, they get along well with others, somebody who's curious about what's coming next in the field, somebody who is a leader, and somebody who wants to make sure that everybody benefits from TAVR and MitraClip and the newest, latest stent. What does it look like if this is your selection process? At Ohio State, it looked like this. We had 3 interventional fellows a year. At least one of those 3 for 8 years in a row was from an underrepresented minority group. You can put processes in place that can enhance your ability to attract and retain diverse individuals. And then number 5, finally, step out, be an activist, be loud, be quiet, be a scholar, be an activist through your scholarly work, and be an activist in other ways, because we have to resist efforts to keep diversity out of higher education and in medicine. I want you to imagine for a minute being a kid that wants to be a doctor. I'm just showing you this to say that those social determinants of health that we all know so well are also social determinants of academic success. And imagine you want to be a doctor and your family moves every 3 years. Hunger is a big part of your daily reality. Your schools are underfunded and overcrowded, and your family's transportation is unreliable, so you can't participate in that after-school program to enhance your math competence. What are the chances that you're going to make it to be a doctor? These social determinants of health, as I said, they can make you feel helpless. They can make you feel like, what can I do about that? I'm a physician, I'm a scientist. What can I do about the fact that a neighborhood is over-policed? What can I do about the fact that there's lead in the paint in these old apartments? What can I do about that? I'm supposed to be opening blocked arteries in the cath lab. But there is something that we can do about it. And whether it's taking a knee for George Floyd or marching at the State House or making revolutionary art to get across your point, or like these medical students of which I'm so proud at UT Southwestern, they are registering voters in the hospital, at Parkland Hospital. So imagine going to the hospital or the clinic to get your medicine refills, and somebody says, by the way, are you registered to vote? Be sure to stop by that booth on your way out so we can get you registered to vote. This is activism, and this is what we all need to be doing. And so in this perspective piece, we simply talked about the fact that we've talked about diversity for a long time. The winds of change are here with resistance to enhancing diversity, which means that we have to do more than talk about it now, not just talk about it, but be about it. And we outline in this perspective piece several things that can be done in a practical way. And I'm going to end with this picture which I think is a powerful picture. And I'm going to tell you, this was a random occurrence. This wasn't planned. I know it looks like it was planned, but it was random. This was one night on call at UT Southwestern. This was the call team. On STEMI call, this was the interventional cardiology fellow, the general cardiology attending, the interventional cardiology attending, and the general cardiology fellow. This is what we can achieve if we believe those things that I showed you in those studies, that diversity is not just a matter of photographs looking good, but it actually saves lives. This is what we can achieve. In conclusion, enhancing diversity will improve healthcare and biomedical research, and we can be successful. Strategic initiatives can be successful. The data shows that. And that if we're all proud to say we practice evidence-based medicine, well, evidence indicates that diversity saves lives. So if we practice evidence-based medicine, then we should act accordingly and make sure that we have diversity in the academy. And I'll end with this image and one of my favorite quotes from one of my favorite men. Dr. King did say that of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. And we've been dealing with that for a long time. And there are several culprits that lead to our health inequities, which means there are several solutions. But one of the most important ones is making sure we have a more diverse physician workforce. Yale University, thank you very much for the invitation to talk to you. I'm happy to be here.
And I'm glad to start. First of all, very powerful. Thank you for joining us. It is a statement to say that you're perfect. Yeah. And I can tell you, I remember being in that same situation. Well, I think that was about the opportunity we have to increase diversity of faculty, fellows, and move people. And my question.
Thank you.
One is, this is a particularly open question. I'd like you to express your perspective based on your time at Ohio State and on the role to support diversification of the population of serve and how you've given us an idea, but do you see that as a what do you see that role, how to economic for change different financial plans? How do you envision what challenges take you that? That's one question. Maybe the second question is, in my career, I guess, I had focused on the construct of enhancing the evidence, guidelines, establishing the concept that we kind of raise eyes, all boats. Is that enough? What do you think about that? And what's the goal of that construct, guideline, in addressing diversity?
Yeah, well, thank you. Thank you very much. And thank you for your complimentary words. So I'll start with the second portion of your question last. I love guidelines, and I think guidelines and having evidence in those guidelines is critically important. As it turns out, sadly, guidelines don't appear to be enough. But what does appear to be helpful is when our accrediting bodies, our regulatory bodies, then hold us to account for those guidelines. So when LCME, ACGME, when the Joint Commission, which I wish the Joint Commission would do more of this, can hold us accountable to following the guidelines. So these are all your STEMI patients. Did men and women have the same outcome? Did men and women both receive aspirin and statin and revascularization? Did Blacks and whites get the same care? And when you get a real punishment, when you're not, that can actually move the needle. So guidelines are a very important part of that. We have seen, though, that just having the guidelines is by itself not enough. But when we put regulatory heft behind the guidelines, especially when you start talking about accreditation, I think that's when we really see things move in the direction that they ought to. The first part of your question was about the role of academic health centers in diversifying. One thing is we have to realize that that diversity, equity, inclusion is not a spectator sport. It won't happen passively. We have to be active about it. And that means that academic health centers have to reach out to the community and do some things like partner with some high schools, partner with some elementary schools. You know, we're living in the time where almost all of our academic medical centers and our teaching hospitals that are non-university hospitals have beautiful, expensive, maybe multi-million-dollar clinical skills and simulation labs. What a wonderful tool to get kids and high school kids, elementary school kids in to practice CPR, to practice intubating mannequins. That is so exciting to them. They go back to their class that they might think is boring, but if they're thinking, if I do well in this class, then maybe one day I'll be intubating patients like I did. So we can use our resources to reach out and have exposure. And then in the academy, as I said, we have to do what we can to de-bias some of our selection strategies. Keith.
Give me a few minutes, okay?
You got it, Keith.
This is my intern. I'm the resident. My partner, or still my partner. I did send out a shout out to Paige Campbell and let them know that you actually have a job and you're actually working. So thank you for joining us.
Yep. Thanks, Keith.
You know, when we think about the that we need to do the work we have done and the opportunity that the program you put in place at Ohio State, Southwestern, have you been actually able to track those who actually have come through the program and see exactly what their career paths and arcs have been after they have left actually these particular institutions? Just to give an example of, a concrete example of actually what the opportunity, if we actually bring it to the table, can present and actually its effect on the communities that we serve.
Yes, thank you for the, thanks for the kind words. And Keith and I go way back, and I'm just proud to be in his presence. So thanks, Keith. Thanks for your comments. So yes, and that's so important. Just like with everything else you do, you have to look at your outcomes. Is it worth the investment? And so just a few things that we had, I can tell you one high school summer program we had at Ohio State called MD Camp, where high school students from underrepresented backgrounds spend 3 weeks really tagging along with our medical students. So they get to see what the life of a medical student is like. What a wonderful thing when at our white coat ceremony for the medical school, we saw some alumni every year of that MD camp. So at least, so they're going on to college was phenomenal. 8 of 10 of them went on to college. And we were seeing further down the line in every class of MD camp of about 30 students, about 3 or 4 of them were in our medical school, and some others were in other medical schools. And some of our programs where we used our clinical skills simulation lab to reach out to high schools. Again, those students going on to college, we have strong data that the students who participated in that program were more likely to go to college than students who did not participate in that program. So when you start way back in the pipeline, that means you're in it for the long haul. It's going to be a while before you see, did they become a cardiologist? Did they go to medical school? But you know, of course, you got to go to college first before you do those things. So, but I'm so glad you asked a question to keep me grounded. You've got to track your data. You've got to see, is this worth the investment? But it looks like the answer is yes. Yeah. Thank you.
Did say that looking at who is more likely to get complex intervention participation, include geography as one variable to understand better, they don't become right. But I would ask, you know, because this goes to like deeper information. Are there differences within understand your appreciation of the verdict here.
Yes.
So that's a person to address.
Yeah, thank you for the question. I appreciate it, and I appreciate your comments. So absolutely, there are geographic differences. So I tried to be sure that everything I showed you was from a study that was looking at a national database. But in those very same studies, they do talk about regional differences. So there are regional differences. There are differences between academic medical centers and non-academic medical centers. So so it's not the same throughout the nation. But when you look at our report card as a nation, it's not good. But your comments are right on. There are definitely geographic differences. Yes. Thank you so much. What a great question, because we always have to be careful when we talk about that data, that we're not saying we want segregation. You know, Black patients see Black doctors and Chinese patients see Chinese doctors. The way to use that data properly is to show the benefits of diversity. So let's get more diversity in the profession. And then you'll have more of those happy accidents where you do wind up with a doctor that shares your background. But even if you don't, you wind up with a doctor who trained with somebody who's from your background, and they're a little more culturally humble and culturally competent. Yes. Mm-hmm.
My question, and thank you, that was wonderful.
Thank you.
I'm actually interested in sort of how we can address the weight barriers, particularly in areas like this where often I think well-meaning for MLK, well-meaning moderates who just think, well, you know, I'm not biased and I just want a meritocratic system, ignoring the fact that because of health, we actually have a very anti-meritocratic system. And you know, I often hear people who see themselves as very progressive, say things like, really, it's almost impossible for white kids to get into Yale. And it's like, well, there are a lot of white kids at Yale. So I know that's not true. Ignoring how much harder it may have been, you know, for students of color to have made it to the point where they're even thinking about applying to Yale. That's just lost. Bridge that gap where for people who are really well-meaning but have implicit bias, and maybe that's more, get into that more in your bias workshops, which I'd love to hear more about as well. But how do we sort of bridge that gap? Do you really think that they're, you know, that they get it and yet aren't actually, there's a bridge between believing that diversity is important and in a way that implements many of the things that
Yeah, thank you for your question. Well, and it's a doozy. And what I mean by that is because there's really no easy answer. I mean, the easy answer, but it turns out to not be so easy in our everyday lives, is just to talk about it. People who are well-meaning, first of all, we need to all just try to be a little more open-minded. Maybe you don't know everything, so try to be a little more open-minded, but we have to talk about it. And that's really hard today, isn't it? I mean, if somebody asks you something about your race, ethnicity, or religion, the immediate thing is to recoil, or maybe recoil with your fist balled up. We've got to get away from that. We've got to get to, you know, if I innocently ask you a question, you know, if I ask a Muslim, I don't know very much about Ramadan. Can you explain Ramadan to me? I should be able to do that without that person taking offense. If they ask me something about Black American culture, I should be able to hear that without taking offense. And so we've got to talk about it more, so we learn, and then we learn what we don't know. So I didn't realize that that if we hold an event that happens to be on a holy day, that is offensive to that group of people. Now you've told me, now I know. Thank you very much. So the easy answer, which is not the easy answer, is we just need to talk more about it and try to have civility when we have these discourses, which I know seems just getting tougher and tougher, but I'm an optimist. I think we can get there. Yes. Thank you.
More effective, more fun. And right now, because of the paucity of underrepresented minorities in medicine, there's a big pull on minorities, like minorities. And you see that play out in the current boards, they're reviewers.
Mm-hmm.
How do you counsel people, how do you support people that feel supported, being underrepresented minority today after academic or feeling very
Well, thank you for your comments and a really great question, and that is compensation. So the way that we lead to people not feeling burnt out, feeling unappreciated, is if you're, if you're always asking the woman to meet with women candidates, if you're always asking the Blacks and Hispanics to meet with those candidates, to talk to those students, to give those lectures, that's okay if they want to do it. Sometimes they don't want to do it, and if they don't want to do it, that's fine. But if they want to do it, then compensate them either. And yes, sometimes that means dollars. But if it's not dollars, then your P&T system needs to give them credit for that. So that if I spend time going out to churches on Saturday to talk about ways to prevent a heart attack, and if I always come and make sure my face is seen to the Blacks who are interviewing, then I should get credit. When you're going to promote me from assistant to associate professor, not only how many papers on my bibliography, but how many of these things have I done to enhance diversity, equity, and inclusion. We need to encode that, codify that in our P&T. Thank you.
Oh,
Thank you so much.
Tell me your name.
Oh,
I'm Sarah.
I emailed you, I work in like the cardiology space, it's a very small space. I had emailed you in like the conference, we ended up having to cover reasons. You're a busy man, I took your head, but I'm a huge fighter. And I also think that, and there's so much work to be done, even in